You need a thumb up. Okay, Dr. Badia here for another weekly episode of Fixing Healthcare from the Trenches. Today, I think we have our most, if not our most esteemed, certainly our most influential guest that we've had until now. Dr. Tom Price is an orthopedic surgeon, keeping with the tradition of getting clinicians who are disruptors and active in trying to improve our healthcare system. And he is a fellow orthopedic surgeon. I'm very proud to say that he also was a U.S. Congressman, and I'll go over a little bit more of his background. But I want to say that he started his career in Michigan. He is a Michigan guy. Both his father and grandpa were physicians, and he used to make house calls with his grandfather at a very young age, and was inspired very much like myself in seeing family members who in Cuba who were physicians. He then he did his medical school as well as undergraduate work at Michigan, and then went to Emory for his orthopedic surgery residency, and then stayed there, settled in a suburb, and that's after founding Resurgence, which I think might still be the largest orthopedic group in the country. He then became a U.S. congressman representing a district in Georgia, and then was for about a 1-year period of time the Secretary of Health and Human Services under the last administration. So he's going to bring a lot of insight. I'd like to now introduce Dr. Tom Price.
Dr. Badia, what a joy it is to be with you today, and I appreciate this opportunity. And I know that you've been working long and hard on trying to solve the healthcare challenges that we have. So it's a great privilege to be with you.
Thank you. Well, I think that there is some progress, and maybe you'll be able to comment with somebody who knows a lot more inside information on some of the recent acts, including there's several bills in the House. One is entitled little cumbersome, Reducing Medically Unnecessary Delays in CARE Act. And then the one bill that apparently got unanimous. I mean, nowadays to get bipartisan support for something shows that the American public really needs this. And that is the Improving Seniors Access to Care Act, Bill HR 3173. Maybe you can comment on those bills.
Yeah, I think that obviously the goal is to get more folks covered and to be able to allow them to access the system in a more streamlined fashion. One of the things that I learned in my nearly 13 years in the Congress was that the title of the bill doesn't always necessarily convey what's actually in the bill, and so you got to be very careful about just saying, yeah, that sounds like a great bill, and then and be supportive of it. The concerns that I have about some of those are that they tend to put more authority in the hands of the individuals who are running CMS or who are in charge of the bureaucracy. That's not always bad, but oftentimes in healthcare, as you know, it is, because they're making decisions that move the decision-making process further away from the physician and the patient and the patient's family. So we look cautiously upon those pieces of legislation, but I'm excited that actually Congress is looking at taking action in the area of healthcare, because so often what happens is that they just cede it to the administration, the president and the executive branch, and then you don't get the people's input into that process.
I see that's very interesting, because the problem, I think, is perhaps a lack of understanding of the process. I think if you ask the average person, they're very frustrated with how they access healthcare, how cumbersome it's become, and this concept of authorization. As you may know, in my book, I have a subtitle that I say authorization is a 4-letter word, which obviously it's not, because it's really an absurd concept. And you bring up some interesting points that if it's going to be even more difficult for the clinicians, the people in charge of our healthcare, then we're not really solving the problem.
That's right.
I want to share, just yesterday, I tried, and I think people know I'm very outspoken. That's why I would never be able to do your job, and I salute what you were able to do for 13 years. There's no way I would get elected, because I can tell you yesterday I had a very unfortunate discourse with one of the major leaders of Blue Cross Blue Shield down here in South Florida, where I simply wanted to meet with him and say, look, we have shared goals. And I'll say this publicly, there is a purposeful veil and barrier between the people who pay for healthcare and the people who actually provide it.
Exactly.
Right. And that is an absurd thing. I just wanted to meet, I don't know what you drink, Tom, but I wanted to meet the guy and just, buy him a bourbon and just sit down. Right. Or coffee.
Well, it'd be those kinds of meetings would be incredibly helpful. And
Exactly.
I mean, your experience highlights the fact that they don't occur. And prior authorization is a classic example. Most patients don't appreciate that. Then when they go to the doctor, the patient and the doctor talk about what it is they think needs to be done in order to either diagnose or to treat a problem. But then the doctor and or his or her staff has to go back and make sure that it's okay with the insurance company, make sure that it's okay with the health plan. Those folks that they're talking to on the line, as you well know, tend not to be clinicians, maybe a nurse, possibly, but oftentimes tend not to be a clinician. And so it's just algorithmic medicine, which doesn't make us responsive to the unique nature that every single patient brings to your door and every physician's door when they go in to see their doctor.
Yeah, absolutely. You hit the nail on the head. Is that the appropriate clinician is the one who should be making these decisions. And if we could cut out all this fat from the cost, because that person who's sitting there at a desk giving you that silly number called an authorization has, as they should, has a salary and benefits, right. and it just ends up being a cogwheel in the system. But I think yesterday was very telling to me when I really wanted to sit down with this person at this insurance company and say, look, we understand. I'll say it. I am a capitalist. I understand that the insurance company wants to make money. I'm fine with that. But what if I told them that we can help you to do that? Because the number of steps a patient goes through, they all have to be paid for to some degree by the insurance company, right? So why not get them to the right person? I mean, you and I, Dr. Price, are both orthopedic surgeons, but we might not be the right person to, give an authorization for a particular spine procedure.
Exactly.
Yeah, we don't know. Now, if for me as a hand surgeon, yes, if I had a hand colleague, an active practicing colleague who weighed in on this, I would be okay with that because, I can make mistakes and we need oversight. But I think that these bills, I don't know what your thoughts are, but do you think that there's several bills right now on this topic? Do you think that this shows that there is an appetite now for real change?
Well, I think that they're nibbling at the margins. The challenge that we have, good medicine makes good business. And I always used to say that for folks. If you take care of the patient the right way the first time and through that process, then you're saving not just the patient money, but you're saving the insurance company money, or you're saving Medicare money or Medicaid money. And so quality medicine, high quality medicine makes absolutely good business sense. Now, the challenge that we have is that in Washington, our healthcare system, as you well know, as well as anybody, is just a glommed on system. It's a system that wasn't thought out strategically. It's one where a decision was made and then another decision was made and another decision was made. And then they tried to patch that decision on and on and on. And that's happened over the last 60, 70 years. And what we end up with is a system that's siloed. So you've got a healthcare system for seniors, for those at the lower end of the economic spectrum, those in the private health system, those in the concierge system, those in the VA, on and on and on. And none of those systems talk to each other.
Right.
And so we wonder why on earth we've got the challenges that we've got. And the reason is we don't have a healthcare system. We've got healthcare systems. And some of them work better than others, but all of them are nibbling at the margins when they try to do these reforms. And I know we'll talk about the kinds of things we would do to fix the system, which is what this is all about. But they have to be higher level things than what we're looking at right now. If you patch prior authorization, if you patch surprise billing, if you patch these kinds of things, you've got a patch. And I promise you that there will be some challenges with those patches, and it may actually have unintended consequences that make the system not more responsive, but less responsive to both physicians and patients.
But even within those systems that you mentioned, there is there's very little intercommunication. I mean, I know back in the Bush administration, there was a big initiative to have a national EHR, right, electronic health record. That hasn't happened. We have what, over 400 electronic medical. Every day I get at least 2 or 3 bot messages to my email box or LinkedIn asking me about my, it's got a whole vocabulary, right? My RCM, right?
That's right.
Revenue cycle management. That's a fancy word for billing and collecting. It shouldn't be that complicated, right? It shouldn't be that complicated. And yet it's actually creating bigger silos, as you mentioned.
Medical records are a classic example. The federal government spent $30 billion mandating that physicians and physicians' offices and hospitals have an electronic medical record. This is good. This is good for the patient. It allows there to be one place where the patient's information is. The problem is that, as you said, there are tens, if not hundreds, of different electronic medical record systems, and they don't speak to each other. So if you think about the real challenge and what the real solution is, it's having the federal government step back and say, okay, we don't want to dictate to you what medical record system you use, but whatever system you use, it has to be able to talk at the upper level to every other system. And unless you do that, then it's garbage in, garbage out. You got one person speaking English, one person speaking Spanish or French or German or whatever it is, and it doesn't work. You can't communicate. You got a Tower of Babel of electronic medical records.
That's a great analogy. It is a Tower of Babel, and my own attempt at trying to improve at least initial access to musculoskeletal care has been this initiative of Ortho Now, and I can tell you that now I'm going to be flying to Wyoming where we're going to be opening one. But I know they're going to be using a different medical record system. So the problem is we can't collect that data to then go to my buddy at Blue Cross Blue Shield and say, look, I'm telling you that when that person has an ankle sprain or back pain, it is much more cost effective to do what you said, to see the right clinician at that right time, because that's where we save the money. And there was an outdated concept now of this gatekeeper, of having somebody go to an overworked primary care colleague who really should be keeping us healthy, right? Should be overseeing chronic problems. And we make our patients go to them to then get this authorization. I mean, it is really an absurd concept.
Yeah, another classic example of what bureaucrats and policymakers think is the right thing. Right. You ought to have somebody see a primary care doctor before they see anybody else. Sounds good, right? But the premise for that is that every primary care physician knows exactly where that patient ought to go. I'll tell you who the best person to decide where the patient goes is the patient. Because they're the one that has the most at stake. So if a patient believes they ought to go to a dermatologist for a particular problem without a referral, or a plastic surgeon, or an orthopedic surgeon, or a GI specialist, or a urologist, or an infectious disease doctor, whatever it is, the patients ought to be the ones that are making those decisions. And when you do that, you actually create a more functioning system and a more responsive system to the end user, the patient. And that's kind of what we've lost.
Yeah, exactly. The end user. I've used that same exact term. Amazing. I remember my mom went to see the famous Augusto Sarmiento. Yeah. Gus Sarmiento, was president of the Academy of Orthopedic Surgeons. Also bilingual, though my mom being an interpreter, she probably spoke to him in English. But my mom knows quite a bit of medicine, and she thought there was a problem with her hip. Well, I'll never forget. Gus said to her, "Oh no, you have the bones of a horse." I mean, her hips were, and yet in that case, that was a rare instance where Dr. Sarmiento said, "No, you need to see more of a belly person. Somebody who's going to understand that your pain is coming from somewhere in the pelvic area, not the hip." Right. But the majority of the times, you're right. The patient does know they need to see an orthopedist versus a dermatologist, right? And we need to have the patients have more control. But that also requires them to be educated. So I'm gonna launch into the 3 initiatives, and that we've already discussed some of mine. So I want to hear what your 3 top initiatives would be to really disrupt and improve U.S. healthcare.
Well, I really appreciate this opportunity, because so rarely do we truly talk about the real solutions in healthcare. And you've asked me to kind of give you my 3 solutions to how to fix the healthcare system that we have. I've got a number more than 3. However, my top 3 are: 1, you got to get folks covered. Universal coverage is
Okay.
absolutely imperative. And some of my conservative friends say, oh, Price, you can't do that. That means the government's going to be in charge. The real thing is that you can have universal coverage without putting the government in charge. You just have to set up the system in the right way. Not having insurance, being uninsured in our system right now doesn't work. When your dad and your granddad or folks in your family were physicians before, and my dad and my granddad were docs, it was a different world. You could take care of folks because the margins were greater in medicine. So the physician, if he or she took care of somebody who didn't have insurance and wasn't able to charge them or didn't charge them, then that didn't affect the bottom line significantly for that doc. Today, however, the margins are getting so significantly small, you can't do that anymore. So everybody has to have insurance. How do you do that? Second thing, you got to make certain that however individuals get insurance, the patient owns the coverage. And whether it's Medicare, Medicaid, private insurance, the employer-sponsored insurance, whatever it is, the patient has to own the policy. And the reason for that is that the insurance company right now, if you recommend something for a patient and the insurance company says, no, we don't believe that's necessary, and the patient calls the insurance company, what does the insurance company say? They say, call somebody who cares, because you don't control your insurance. Somebody else does, your employer or the government or somebody else. So if the patient owns the policy and can move that policy money based upon their needs and their desires, then the insurance company has to be responsive to the patient. And then finally, the third one is to make certain that we regain the physician-patient relationship, regain the trust between doctors and patients. The only way to do that I know of is to make certain that physicians and patients and families are the ones that are making medical decisions and not anybody else. Right now, you got all these other folks out there that are making medical decisions. Used to be that we didn't allow the corporate practice of medicine, businesses making medical decisions. Now we've got a veiled corporate practice of medicine where insurance companies or employers or government are making medical decisions. They don't say that. That's not how it's written, but that's the effect of the system that we have. So getting everybody covered, making certain that the patient and his or her family owns the health insurance, and making certain that we restore that physician-patient relationship and trusting relationship. That'll go a long way to solving the true problems that we have.
That's amazing. In fact, that's kind of the first time I remember it articulated that way. Point number 2 of the patient owning their insurance. Let me ask you, you've been on the Hill for quite a while. The current stakeholders, whether it be the big insurance companies, the PBMs, pharmacy benefit managers, and big pharma and all. I mean, how difficult is it going to be, in the swamp, right, to get the lobbyists to finally come together and make that kind of change, so that they don't feel threatened? Because in the end, I think there's enough money in the system for everybody to do well. Correct? So how do you think we can achieve that?
There's more than enough money in the system. We waste so much money in healthcare, more than enough money in the system to be able to have a system that's actually, again, responsive to patients. You ask, how difficult is it going to be? Extraordinarily difficult. We've been trying for decades, and I know you've been working at this for a long time. I started in this in the late 70s, early 80s, trying to move us in a better direction. The problem is that the folks that are most at risk, that is the patients, are the ones who are least organized and have the fewest resources in order to affect the system. And so we all rely on advocates out there to say, okay, help us out, whether it's AARP, whether it's an advocacy group for a specific disease or illness, whether it's professionals, whether it's docs that are relying on their professional association. And all these folks have a limited view about what it is that needs to be fixed. And that's why we get these little glommed on solutions that are passed in DC. That's why we need statesmen and stateswomen in public policy arenas, the decision makers, the policy makers, to look above all of that, to look over all of that, and see that the system needs to be fixed from the top, as opposed to just these little nickel and dime solutions that may help, but they don't solve anything at its core. So extraordinarily difficult. It's going to take a group of patients and others out there to advocate and say, we know what the kinds of solutions look like, and they're not small. They're big. They're major solutions, and we don't want the crisis that we know is coming, which is
Right.
where you get rationing of care because the system then
Definitely.
can't afford to be able to
And,
provide
and
it.
the shortage of physicians because they're
Absolutely.
frustrated. I mean, I have two colleagues, I've said it before, who are retiring this spring.
Yep.
One was my intern. My intern
Yeah.
is retiring well before and another was a fellow co-resident. So this is a big storm on its way.
It is.
The question is, how do you get the public to care as much about this as they did, for example, with the whole, defund the police or Black Lives Matter? I mean, those were social movements that did create some change. This is 20% of our economy, healthcare.
Yeah.
People only seem to care when it affects them or a loved one. And this has to change.
You're absolutely right. It's education, and you really can't blame folks. Most folks are busy out there.
Yeah.
It's about 4% of the population that is accessing the healthcare at any one point in time. 4%.
No, I haven't heard that.
And about half of them are mad as they can be. That means 2% of the population are desirous of that absolute acute change that is so necessary from a fundamental standpoint. But that 2% isn't constant. That 2% is dynamic. It changes. You may be accessing the system one day, the next week the problem solved, or the next month the problem solved, and somebody else that's in that 2%. So they're hard to mobilize. So education progress has to occur.
But education and is partly based on, let's face it, the media. I mean, that's how people learn. And the question is, when is the media going to care about this issue as much as they did about, say, racial disparity and issues? Yeah. When are they going to care about the fact that I think healthcare is a pretty important topic, but the economics of it is overwhelming. I mean, 20% of our GDP now. So the question is, when is an interview like this going to actually be noticed by popular media and say, let's expand this. Let's take this beyond an 18 or 20-minute talk and really bring this to the public. Yeah. I have not seen that yet.
No, nor have I. And I remain hopeful and prayerful that we could that can actually happen. However, my concern is that it won't happen until we have a true crisis. And that crisis is not far away. It's not 30 years, 40 years, 50 years. It is literally right around the corner. And it gets to the heart of the lack of funding that's going to be available for the government programs, especially Medicare. When Medicare runs out of money, which means they won't be able to provide the services that have been promised to the seniors, then you'll have a crisis on your hands, because the only thing that the government can do is then ration care. And it's likely that that's what they will do. They won't call it that, but that's what they will do. And then there will be a crisis. And then you will see people get up in arms and complain about it. And that's when the media will begin to pay attention. The concern that I have about that, I'm fearful that is going to happen. The problem is that when that happens, you don't know what the outcome is going to be, because our dear friends on the left will say the solution has to be for the government to take more control of healthcare, not less.
Which is already the problem, yes.
Which is already the problem, exactly.
So you had founded this, you were, I think, a charter member of the Association of American Physicians and Surgeons, right? The AAPS, which is really, tends to be a conservative group, but really cares about our healthcare system. And was founded many years ago. And yet there's been, there's been very little traction of this. So your group, that group has been pointing out these problems for quite a while. So
you're absolutely right. And one of the things that gives me pause as well is that I'm in the waning years of my engagement in public policy and in medicine, and I appreciate that and understand that. But when I started, the average physician getting out of medical school, he or she, they viewed their ideal role in medicine was in private practice and basically owning their own business. That's completely flipped now, so that the average medical student getting out, he or she does their ideal situation that they envision for themselves in practice is to be an employed physician. And when you have employed physicians, then the individuals making decisions are higher up and tend to be further away from the direct patient care. That's a danger that we have. So it's a real problem.
Everything is a pendulum, though, right?
Right.
Down in society. So I think it's starting to swing to swing back to some degree. Some of these employed physicians are realizing that it's not that gratifying.
Right.
And yes, they start out with great. I experienced this myself with a colleague I wanted to bring on. They want that initial great package. Sure, that sounds great. But then later on, they don't have the control necessarily. And
That's right.
even the doctors. So we, actually, I'm proud to say we are way over time. It's only because these are great. So, and I have to give my 3 initiatives, which we discussed all. So my first one would be oversight, not authorization. They're
Right.
very different, right? We do need oversight. We make mistakes. There's bad apples amongst doctors, like there are amongst attorneys. Well, I won't go there, but or plumbers or accountants, right? You mentioned also right clinician at the right time.
Yep.
That right there saves a lot of money. Medicine is too complex nowadays to have, the country doctor like your grandfather. You
right.
Can't know everything, right? And the last one is what we're doing right now, which is public education. But I want to add something to that. We need public engagement.
Yes.
And that is what we're not getting. I can tell when we put this on social media, when, we have, a couple people who forward this, but boy, if I post a picture of of my sister's cute dog, there's, thousands of, and that has to change. People have to care about this.
Yeah. I can't rival that cute dog. I'm sorry.
Yeah, that's right. See, we all like that. Dr. Price, really been a pleasure and an honor to have you on our podcast. If there's ways that we can escalate this discussion, I'd love to hear thoughts from the listeners and see how can we really make some changes. I think we are, as you said, nibbling at the margins, but yep. This needs to be a real movement.
Well, I look forward to that feedback as well. Thanks for this opportunity, and keep up the battle. It's an incredibly important battle for the patients of this country.
It is. Thank you. Bye-bye. Thank you, everybody.
Bye-bye. Be well.